Hello, today we'll be discussing about the topic on nutrition pathology. My name's Jeremiah Pusa. Let us go together. So at the end of this session, we want you to understand the nutrition pathology, to understand the protein and energy malnutrition, to understand eating disorder, to understand and identify vitamin deficiency diseases, explain obesity and its clinical consequences. So before we dwell on those objectives that we want, let us start with understanding of what are the nutritional diseases. So nutritional diseases or nutrition pathology deal with all diseases related to nutrition. These are any of the nutrient-related diseases and conditions that cause illness to human. They may include deficiency or excess in the diet. Here we are speaking of obesity that is caused by excessive nutrition, or eating disorder that can cause some people to have loss of weight. Chronic diseases such as cardiovascular diseases may also be related to the excessive hypertension, may be related to excessive nutrition. Cancer, which may be related to some deficiency of some important nutrients or vitamins. Diabetes mellitus may be related to the excessive nutrition and other things related to that. Nutrition diseases also include developmental abnormalities that can be prevented by diet. These are all the disease that can happen, but they could be prevented either by mother taking some nutrients or doing something that could prevent the occurrence of that particular disease. There are also hereditary metabolic disorders that respond to dietary treatment. This, if they happen, they may categorize them as nutrition diseases. The interaction of food and nutrient with drugs, food allergies, and other intolerance may also be included, because some people are sick because they are eating foods which they are intolerable to them. Therefore, they cause them to diarrhea, to lose weight, and potential hazard food supply may also be cause of diseases. Because assume someone is eating toxic aflatoxin from food product with fungus, may end up causing liver cancer. So all diseases which are related to nutrition, either someone is taking food excess or is taking food less or in deficiency, or diseases which are related to whereby someone is taking that particular food and inside there is toxic substance that is causing diseases, altogether we categorize them as nutritional pathology. So a health diet should provide sufficient energy in form of carbohydrate, fat, protein, and for body daily metabolic needs. So you need all of them, essentially, as well as non-essential amino acid, fat acid. They are used for building the body. They are building block for synthesis of structural and functional protein and lipid. So if they are not there or they are not sufficient, automatically you may end up having some problems. Vitamins and minerals, which are functional in terms of acting as coenzymes or hormones, are very vital in metabolic pathway. Therefore, some people with the deficiency of coenzymes or deficiency of coenzymes, as for example, they are secondarily caused by vitamin deficiency or mineral deficiency. Some hormones are not functional well because of deficiency of mineral vitamins. Therefore, in this case, when we're speaking of vitamins and minerals, they are very important component of metabolic pathway. For example, in terms of rickets diseases, when you are lacking enough supply of calcium in the body, or they are not well absorbed, the phosphates. These are also important component of structural component of the bones and other function of the body. So number one component of pathology, nutrition pathology, is malnutrition. And here we are speaking of primary malnutrition and secondary or conditional malnutrition. On the primary nutrition, this one or all these components are missing from the diet. When you don't have carbohydrates, you don't have minerals, you don't have proteins, you don't have vitamins. If they are lacking the food and you get one of the disease, then the main cause of the disease would be categorized as primary malnutrition, because you are lacking those particular components of the food which are important. When we're speaking of secondary condition or malnutrition, the dietary intake nutrient is adequate, meaning that you are receiving all those what you have listed before, but malnutrition results from nutrient which is either malabsorption. You have eaten the food but it's not well absorbed. Maybe you are getting diarrhea and that particular kind of things. Impaired nutrition and utilization or storage. Maybe your liver is not functioning well, or there is something that is not happening. Maybe you are having diabetes, glucose not taken well. Excessive loss, maybe you are losing too much than it is retained in the body. Increased requirement, either maybe when you're speaking here of someone who is having chronic diseases whereby nutrients is taken more, or someone who is pregnant. All these conditions, they may cause someone to have malnutrition, but not actually from the lack of food which is required, but rather inability of the body either to store it or to absorb it, or to make sure that it is utilized as required. So the causes of secondary nutrition can be grouped into three categories. So they either GI diseases. This is the gastrointestinal diseases which might cause either malabsorption of the food is not absorbed well, chronic wasting diseases, acute critical illness. All are these are important components of causes of secondary nutrition. In general, what are the causes of dietary insufficiency? Now we say those we need carbohydrate, we need protein, we need minerals, we need vitamins, we need clean water, but there are some moments that we cannot get them all. And why? What are the major causes? Here we have a list of 6 major causes, of which the number 6 is also there is subcategories. Here, number 1 is poverty. If you are poor, you cannot get all those nutrients. That's why when you're speaking of this disease, we'll speak later on the kwashiorkor. Marasmus is more common in less developed country because people cannot balance. They have starch but they don't have protein. They have protein but they don't have starch. They don't have minerals. So this is important. Another component is ignorance. If you don't know exactly what it means by balanced diet, it is also difficult. You may have all the food around, but you may be preferring taking only protein, taking only starch, but in a real sense you're required to balance all those food. You need protein, you need carbohydrate, you need minerals, you need vitamins and all other food around. But ignorance may cause some people not to eat as they required. They end up eating one kind of food and they end up having malnutrition, either obesity or deficiency. Chronic alcoholism. People are taking too much alcohol. Most of them do forget eating, and some of the consequences of alcohol also goes to the vitamins. Like they end up not having enough some of the vitamins which are important for the body. Acute chronic illness, that this may cause problem because people who are sick either acutely or chronically, they may end up maybe not having good appetite, not eating enough. Self-imposed dietary restriction, like for the people who don't want to be overweight, they have fear but which is not real, or they are having some other imposed restrictions. Other causes, they can be either GI diseases, acquired inherited malabsorption syndromes, specific drug therapy, or total parental nutrition, whereby someone is not allowed to take food by the mouth, or maybe is just allowed to take it through blood vessels. Here there are people who are having like esophageal cancer, stomach cancer, and that kind of people. So the deficiency of food that we have said, it is categorized as protein, energy, malnutrition. When you say protein, energy, malnutrition, here this manifests as a range of clinical syndrome, all resulting from dietary intake of protein and calorie that is inadequate to meet the body demand. So protein, energy, malnutrition, here we mean that someone doesn't take enough protein, doesn't take also enough carbohydrate. Therefore, the body is inadequate to meet the body demands. The body is not able to function well because it has deficiency of those important components. The two ends of the spectrum of syndrome are known as marasmus and kwashiorkor. The marasmus is mostly caused by inadequate of calories, and kwashiorkor is mostly caused by inadequate in terms of proteins. So it's considering this condition an important point that need to be considered here. We have two proteins compartment, that is somatic compartment and visceral compartment. And when we are speaking of somatic compartment, in protein compartment, where this represent all skeletal muscles, the protein which are available in skeletal muscles, affecting more severely in marasmus. But when you're speaking of protein component, there is another component which is called the visceral compartment. This is represented by protein stored in the visceral organ, primarily in the liver, and they depleted more severely in kwashiorkor as well. So these two compartments are regulated differently, and we will see it. Marasmus, this is the term originating from the word marasmos, meaning wasting. So these kind of people, they are mostly children, and it is considered to have, a child is considered to have a marasmus when weight level fall to 60% of the normal sex, height, and age. And the marasmic children suffer growth retardation and loss of muscle mass as a result of catabolism and depletion of somatic protein compartment. How do they become so thin that they don't have muscles? Because now we say the energy is coming from carbohydrate. If you don't have carbohydrate, which causes marasmus, your body will go for alternative source of energy, which is fat. Then it will utilize your fat. When fat are already over, your body will try another source, which is protein. Now proteins are your muscles, so they'll be taken away, and at the end, this may lead someone to be wasted, children especially. So this is seen to be adaptive response that the body provides with amino acid and other source of energy, because it utilizes them as source of energy. Of interest, the visceral protein compartment, which presumably is more precious and critical for survival, is depleted only in marginal. So serum albumin level are either normally or slightly reduced in people with marasmus. In addition to muscle protein, subcutaneous fat is also mobilized and used as fuel. So they don't have fat at all, they don't have protein at all, and they have that deficiency. High level of corticosteroid can contribute to lipolysis because they are producing a lot of corticosteroid. Again, cortisol, we say, not corticosteroid, cortisol. With such loss of muscles and subcutaneous fat, the extremities are emaciated. They are very thin. By comparison, the head appear to be large for the body. When we compare them, you'll see it later on. So anemia and manifestation of multivitamin deficiency are also present to this kind of children. But of important component is there is evidence of immune deficiency, particularly T-cell mediated immunity, of which this may end up causing these children to have high risk of being infected by different infectious diseases. Hence, concurrent infections are usually imposed to these children, and they have very weakened immune system, or the immune system is not that good. You can see the child highly emaciated. There's no muscles that have been all taken. That's what is happening. On the other hand, the kwashiorkor occur when protein deprivation is relatively greater than reduction in total calories. So this is the most common from protein energy malnutrition seen in children who have been weaned too early. This happened for children who have been weaned too early and subsequently fed almost exclusively with carbohydrate diet. So they end up having high level of carbohydrate, and they don't have enough protein. So for the mother who feed the child from up to 2 years, children are likely to have this particular problem, because milk have a lot of proteins, and for this disease someone is sick because of lack of protein. Marked protein deprivation is associated with severe loss of the visceral protein compartment, so resulting in hypoalbuminemia gives rise to the generalized dependent edema. So these children, they will have edema, lower limb edema, even they have like abdominal ascites. The weight of children with severe kwashiorkor typically is 60 to 80% of normal. However, the true loss of weight is masked by the increased fluid retention. So you cannot see exactly that these children have lost the weight, because with loss of protein, which is albumin, the most common protein in the body, or the most abundant protein in the body, what happens is they end up not having enough oncotic pressure, and they don't have enough pressure which can pull the water from interstitial tissue to the bloodstream. At the end, they have a lot of fluid, extracellular fluid, which is called edema. So there is a relatively sparing of subcutaneous mass, and modest loss of this compartment may be masked by the edema, and therefore cannot see it very well. Actually, clinically, these children with kwashiorkor, they have generalized edema, skin lesion with alternating zones of hyperpigmentation, discrimination, and the hyperpigmentation of giving the flank pain appearance, flank paint appearance. Hair change include loss of the color and the alternative bands, pale and darker colors, staining, and fine textures. The hairs, because the hair, they're proteins, so they will have them very thin. Other feature includes enlarged fat liver, resulting from reduced synthesis of carrier protein, compartment of lipoproteins, development of apathy, listlessness, and loss of appetite may happen for these children. So vitamin deficiencies are likely to be present as they are defect in immune and the secondary infection. They can be common to them. Kwashiorkor, the inflammation caused by infection produce catabolic state that aggravate malnutrition. Of note, marasmus and kwashiorkor represent two ends of spectrum that is considered to overlap exist. So at the end, they mostly exist together. The two main primary protein energy malnutrition syndrome are marasmus and kwashiorkor. So secondary protein energy malnutrition is common in chronically ill and hospitalized patients. A particularly severe form of secondary protein energy malnutrition is called cachexia, often developed in patients with the advanced cancer, because this type of people get secondary protein energy malnutrition because they don't get enough food, they don't get protein, they don't eat carbohydrate, and then they will have deficiency of both too, the protein and carbohydrate. The wasting is all too apparent and often present with go on to cause death. And although loss of appetite may partly explain it, cachexia may appear before appetite decreases. So the issue here is not just not taking food of carbohydrate and the protein only, but also there's high catabolism which is taking place due to the disease, advanced cancer diseases, and other metabolic activities which cannot easily be seen. So when you look into 10 different between kwashiorkor and marasmus, you'll identify that kwashiorkor develop in children whose diet are deficiency of protein, and for marasmus is due to deficiency of protein and cut calories. And for the age-wise, it occurs in children between 6 months up to 3 years, and but the marasmus is common for infant under 1 year of age. Kwashiorkor has subcutaneous fat is preserved, but marasmus, the subcutaneous fat is not preserved. Edema is present in kwashiorkor, and edema is absent in marasmus. There is a fat liver which causes the enlargement of the liver in kwashiorkor, but there's no fat liver in marasmus. Ribs are very prominent. Ribs become very prominent, but in the marasmus, but in the kwashiorkor, the liver, the ribs are not that very prominent. There is a thajiki, and but in terms of marasmus, alert and irritable, and in terms of muscle wasting is mild or absent in kwashiorkor, but very obvious for the marasmus. There is a poor appetite for kwashiorkor, but also when you come to the marasmus, they are having very high appetite, and they eat too much. So the person suffering from kwashiorkor needs adequate amount of protein, but for the marasmus, again, they need adequate amount of proteins, fat, and carbohydrates. So you can see the demand for people who are having marasmus is higher than the demand of people who are having kwashiorkor, besides the fact that they have common denominator, which is protein. So secondary protein energy malnutrition, when we speak of cancer and cachexia mechanism, the underlying mechanism are complex. This involves cachexin, such as proteolysis induced factors, which are secreted by tumor, cytokine, particularly tumor necrosis factor, which are released by the part of host response and expands tumor, Both type of factor directly stimulate degradation of skeletal muscle protein and cytokines, such as tumor necrosis factor also stimulate fat mobilization from lipid store. So tumor necrosis factor, the cytokines, tumor cells, these are secreted by the cancer cells. Therefore, these are also responsible for degradation of skeletal muscle protein, and but also in terms of mobilization of lipid store. Hallmark of anatomical changes in protein and nutrition. First of all, what are you going to see as manifestation? First of all, you will see growth failure. You will see peripheral edema in kwashiorkor. You will see loss of body fat and atrophy of muscle, more marked in marasmus. Morphology in kwashiorkor, the liver in kwashiorkor is enlarged and fat, as we said. In kwashiorkor, the small bowel show decrease in mitotic index. It's crypto and glands, mucosa atrophy and loss of villi and microvilli. This may cause problem because at the end, if someone is having prolonged kwashiorkor, the microvilli and villi, they are not there, crypto glands are not there, mucosa become atrophied. This reduces the ability of the intestine to absorb nutrients, and at the end, these people may end up having diarrhea because of lack of this. Bone marrow may be hypoplastic, mainly as a result of decreasing number of red cell precursor as in marasmus, and this may cause anemia. That's why it's associated with anemia. Anemia is usually present, most often hypochromic microcytic anemia because lack of nutrients. If you're not getting other nutrients, you're more likely not getting even the iron. Brain shows cerebral atrophy, reduced neurons, and impaired myelination, which are a very important component for neuroconduction. Other changes, there is a thymic and lymphoid atrophy, bone marked with the kwashiorkor than in marasmus. So if you're having thymic and lymphoid atrophy, this again may impose risk of infections to people because thymic is responsible for development of T cells, and lymphoid atrophy also may be responsible for causing severe infection because this is the place whereby T cell and B cell meet together with antigen presenting cell, e.g. macrophage and dendritic cells, whereby they work together to produce antibodies and memory cells, which are responsible for keeping our body in good surveillance of immunity. Again, anatomic alteration induced by intercurrent infection, particularly with endemic helminths and other parasites, may be there. Deficiency of other required nutrients such as iodine and vitamins may also happen because they go hand in hand. So as you see here, the kwashiorkor baby looks like not that wasted, but this, I can tell you, this is mostly the edematous tissues, not that much that is not wasted. But for a child with marasmus, it's really wasted. The head is proportional to body. It seems like the head is too high, it is too big, and also they are eating too much when compared to this one. The good appetite, and those are things that may happen. So that was the discussion of kwashiorkor and marasmus, and I think you have understood a little bit about it. Let us go direct to the eating disorder. In eating disorder, we are having anorexia nervosa and bulimia. So these are self-imposed dietary restriction disorders, and they are two kinds. Anorexia nervosa is the state of self-induced starvation resulting in marked weight loss. Here in anorexia nervosa, someone just stop eating by a Friday to be that much fat, and for that reason they are not eating. They don't like getting food, and they become thin. They cannot. I think that there is more than just stopping eating. They become very thin. But when speak of bulimia, is the condition in which the patient bingers on food and then induces vomiting. Here, in bulimia, someone may eat a very large amount of food, and later on a little bit, like he or she may go, mostly ladies, may go to toilet again, inducing vomiting. So that is called bulimia. Bulimia is more common than anorexia nervosa and carries better prognosis when compared to anorexia nervosa, because in anorexia nervosa people lose weight and they end up dying. But for bulimia, a little bit people are more fatter, so they are keeping eating, then they induce vomiting. Anorexia nervosa is a state of self-induced starvation resulting in marked weight loss, and anorexia nervosa also occur primarily in previous healthy young women who have acquired obsession with the attaining and maintaining thinness. So there are those young ladies who they have been told, okay, you have to remain young, you have to remain thin, missy. So these are things that may happen, and they end up restricting themselves taking food, sufficient amount of food, and therefore they get the anorexia nervosa. This is challenging, and they become very thin, and clinically they may end up having more other problems. So clinical findings in anorexia nervosa generally are similar to those in severe protein energy malnutrition. So because if they're not taking food, means that they're not having nutritions. They don't have enough protein, they don't have enough energy, and therefore they end up with all those problems that we listed previously. This is the lady, is given everything. She doesn't want anything. Very thin, she look wasted, but she feel like very nice because that is what he is aspiring to. In addition, the effect of endocrine system are prominent. They get amenorrhea resulting from decreasing secretion of gonadotropin releasing hormone. They can get also decreasing thyroid hormone release, including cold intolerance. They can become cold intolerance. They feel very high cold. They have bradycardia. The heartbeat is very slow. They get constipation, changes in skin and hair. Dehydration and electrolyte abnormality are frequently seen. Skin become very dry and skull may be tinged as a result of excessive carotene. So all this may happen in their life and they may end up dying. So body hair may be increasing, but usually fine and pale, lanugo, like in the child who have been born before the day, lanugo, you can see them. The bone density is decreased, so most likely because of low estrogen level, which is mimicking the postmenopausal, because if they don't have good hormone balance, mean that they are menopausal, they are almost menopausal women. They don't go in their normal menstruation cycle, so they can have low estrogen. And if you have a very low estrogen level, your bone metabolism is not that good. Bone density decrease because calcium is not that stored in the bone. As unexpected with severe protein energy malnutrition, anemia, lymphopenia, and hypovolemia may be also present, which may end up causing also other diseases related to the immune. A major complication of anorexia nervosa increases susceptibility of cardiac arrhythmias, sudden death, and due to hypokalemia. They don't have enough potassium, and therefore they may end up having these cardiac arrhythmias with being suspected to sudden cardiac death. Bulimia, as I said here, the challenge is a condition in which patients bingo food and then induce vomiting. In bulimia, bingo eating is norm. They eat a lot. Huge amount of food, principally carbohydrates, are ingested only to be followed by induced vomiting. Although menstruation irregularities are common, amenorrhea occur in less than 50% in bulimia. So medical complications related to the induced vomiting and chronic use of laxative and diuretics. So you see the ladies taking a lot of food, and finally they may end up having some other problems. These complications for bulimia include electrolyte imbalance, hypokalemia, which is predisposed patient to cardiac arrhythmia, pulmonary aspiration of gastric content because of the induced vomiting. When they are vomiting, some content may go to respiration system and we can get pulmonary aspiration, which may end up having infection in the respiratory system. There might be esophageal and stomach rupture because as you are vomiting, there is high force which may cause rupture of the esophagus and stomach. There was no specific sign and symptom for this syndrome. The diagnosis must rely on comprehensive history and psychological assessment of the patients. Let us go to the vitamin deficiencies. These are the fat-soluble. We have fat-soluble vitamins, the ADEC, and water-soluble vitamins. This distinction between fat and soluble and water-soluble vitamin is important. Although fat-soluble vitamins are more readily stored in the body, they may be poorly absorbed in fat malabsorption disorder caused by disturbance in digestive function. For example, if someone is not having enough amount of products which are responsible for the absorption of cholesterol in the body, or for the fat absorption in the body, they may end up having a lot of problems of not absorbing also the vitamin, because these vitamins depend much on presence of fat for them to be absorbed. Chylomicron is very important component. So for people who are having problem with gallstone, and they cannot produce enough bile, they may end up also having this particular problem, because bile is, by one way or another, is responsible for emulsification, and if it is responsible for emulsification, then if you don't have enough bile, you may end up having this particular problem. You're not absorbing a lot of fat-soluble vitamins. So, certain vitamins can be synthesized endogenously in the body. Vitamin D from the precursor steroid vitamin K, and biotin by intestinal microflora. Niacin from tryptophan in the body are essential amino acid. Notwithstanding, with endogenous synthesis, a dietary supply for all vitamins is also very essential for health. Deficiency of single vitamin is uncommon, and single multivitamin deficiency related to the protein, energy, nutrition are also very common. So here are some of the vitamins and the effect of their deficiency in the body. Vitamin A deficiency can cause night blindness, because this is responsible mostly for seeing very well. Xerothlavia can happen, squamous metaplasia can happen, vulnerability to the infection also can happen. Vitamin D can cause deficiency, can cause rickets in children, can cause osteomalacia in adults, and vitamin E can cause spinocerebral degeneration, which may be dangerous. Vitamin K can cause bleeding diathesis, because it is a very important component of a clotting cascade in the body. Water-soluble vitamins, here we are speaking of vitamin A, vitamin B2, vitamin B1, B3, B5, B6 and more. And vitamin BA, if it's not there, you get dry and wet and febrile beriberi, Wenke-Korsakoff syndrome. This mostly happens for people who are taking alcohol. Vitamin B2 can cause chelosis, stomatitis, glossitis in the tongue, dermatitis, corneal vascularization. All this again is very dangerous in the body. Vitamin B3, which is called niacin, another way it can cause peregrine, which can cause dementia, dermatitis, diarrhea, and sometimes it can end up causing death. Vitamin B5, which is called the pantothenic acid, no syndrome is recognized for this vitamin deficiency. Vitamin 6 can cause glossitis, dermatitis, peripheral neuropathy, and therefore it is very important for them to be taken care. Vitamin B7, no clearly defined clinical syndrome. Vitamin B12, megaloblastic anemia, degeneration of posterolateral spinal cord tract. Vitamin C is responsible for scurvy if not there. Folate is responsible for megaloblastic anemia, but also for defect, fetal defect at the back. So finally, we have another problem related to nutrition, which is called obesity. Obesity is the state of increased body weight due to adipose tissue accumulation that is sufficient magnitude to produce adverse health effect. The measure in common usually is BMI, which is called the body mass index, and skin fold measurement, together with the various measurement circumferences, particularly waist hip circumference ratio. Normally, the BMI is closely correlated with the body fat, and it is generally agreed that BMI higher than 30 impact the health of the health of the particular person. So when you have 18, 25 to 24, this is normal. 25 to 30 overweight, and greater than 30, that is obese and is dangerous. So the untoward effect of obesity are related not only to the total body weight, but also to the distribution of the stored fat. Central, there is visceral obesity, in which fat accumulates in the trunk, in the abdominal cavity, in the mesentery and around viscera. It's associated with the high risk of several diseases, that is excess accumulation of fat in diffuse distribution subcutaneous tissue. The etiology of obesity is complex and incompletely understood, involved genetic, environmental, and psychological factors. Obesity is disorder of energy balance, two sides of the energy equation, intake and expenditure. Here, the intake is higher than expenditure. Therefore, you are storing a lot of food inside, either by terms of carbohydrate or fat, but they are stored in form of fat, because even excess carbohydrate can be converted into fat. so that the body weight is maintained within normal range. So clinical concerns of obesity, they can cause atherosclerosis, hardening of the blood vessels, type 2 diabetes mellitus because of insulin insensitivity, hypertension because of atherosclerosis, and many other things that involve constriction of the blood vessels, narrowing of the blood vessels, cholelithiasis because someone who is fat, they are more likely to form the stone in the gallstone. Or osteoarthritis, this is the particular problems in the joint, which is not caused by inflammation of the joint, but with the disorders in the joint, closeness because of obesity and overweight and overuse of the joints. Cancer, this is esophageal, thyroid, kidney, gallbladder, endothelium. They can be caused hyperventilation syndrome. This is mostly happening for people who are having obesity. Non-alcoholic liver diseases, this can happen, causing to steatohepatitis, hyperlipoproteinemia, hyperinsulinemia. This can also happen. So, in summary, kwashiorkor is characterized by hyperalbuminemia, generalized edema, fat liver, skin changes, and defective immunity. Marasmus is characterized by emaciation resulting from loss of mass and fat. Secondary protein, energy, malnutrition occur in chronically ill and patient with advanced cancer. Anorexia nervosa is self-induced starvation. Bulimia is condition in which food being alternative with induced vomiting. Obesity is when BMI is more than 30 kg. When than 30 kg, when it is calculated as BMI. Otherwise, you can review the questions, and we have used the following for reference. Rapid review pathology, Robbins and Cotton pathology-based disease, textbook for pathology. All the best for the preparation of exam and the other offers. Thank you very much.